To me, actually, there have been two interesting things that have begun to emerge this year, which have been coming along and I think have been reflected in the discussion at the meeting. One is the sort of convergence of genomics and immunology. And we're beginning to see now more and more genomic biomarkers that predict for either sensitivity or resistance to immune therapies. We're beginning to see some convergence of immune therapies with traditional forms of cancer treatment. So, the work that Guido Kramer and others have been doing for many years now, showing that even cytotoxic chemotherapy might actually work by stimulating an immune response. We're beginning to see, the way in which these different types of therapies are being combined and sequenced, and still a lot more to learn there. But whereas in the past, I think there's been this sort of mindset that there's genomics and then there's immune therapy. I think what we're seeing this year is that these two fields are coming together in very notable ways, and so it's likely that we'll continue to see this sort of interaction where genomic therapy might predict which immune therapy might work, or the genomic test might predict which immune therapy might work best, or that sort of thing. And I think that's interesting. The other thing that's been interesting is we've heard a little bit about it at this meeting. So we're beginning to see again the sort of the emergence of various sorts of sophisticated predictive algorithms. The input to which is some sort of genomic or molecular profile, and the output of which is some sort of prediction regarding the optimal drug or drug combination to use for a particular patient. And if you believe that the sort of highly personalized N-of-1 approach to treatment is necessary, then you're going to need that sort of analysis to be able to determine which of the literally millions of potential drug combinations is the best one for a particular patient at a particular point in their course of treatment. And so the development and the validation of these algorithms is very challenging, but I think we're beginning to see more and more of them appearing on the scene. And so Watson's really not so much an algorithm as it is just a big knowledge base, if you will. I think some of the we saw I think some of this in Ali Koliamini's presentation this morning about their ability to profile tumors and identify drugs, some not even cancer drugs, that might actually have activity against that particular profile in that particular tumor. And the profiling, of course, is very sophisticated and complex, because we're talking not just about genomic profiling, but proteomic profiling, and merging the two, and having some sort of an algorithm that, based upon the analysis of the different features of the profile, identifying drugs that might seem to work best. It sounds great, and there's certainly some evidence in preclinical models that can work. Validating it in the clinic is going to be much more complicated. Well, that's right, and then you start to layer in, some of the other things like what's the importance of the metabolome. We heard about from Guido Kramer talking about the fasting state, and that animals that are subjected to significant weight loss seem to respond better to cancer treatment. There's all the emerging data now about the role of the microbiome and what its impact might be on the immune system and on the effectiveness of immune therapies, or on the effectiveness of various cellular therapies. So, trying to assimilate all this information and use it to construct the ideal cancer therapy for an individual person is going to depend in the future an awful lot on, what's the genomic profile of the tumor, what's the proteomic profile of the tumor, what's the immune profile of the tumor, what's the metabolomic profile of the tumor, what is the nutritional state of the patient, what's the state of the patient's microbiome, and how you're going to be able to take all these pieces of information and put them into a simple way of distilling it to a treatment recommendation. I think is a huge challenge, but that in a sense is really where highly personalized medicine needs to go. There is that, but what you can't forget, of course, are an understanding of the patient's preferences, the patient's goals, and so the whole discussion always has to start with what does the patient understand about their illness? What's the prognosis? What's the possibility of cure? What are the treatment options that are available, given what the possible treatment outcomes could be? If you're going for cure, there's one discussion. If you're going for prolongation of survival but not cure, there's a completely different discussion. And then, of course, you still have to factor in the cost of the treatment, because there are many patients for whom these treatments are simply unaffordable, or even if they are affordable, they produce so much financial stress that they actually disrupt people's quality of life, and can put whole families in jeopardy just by paying for a few months of additional survival. I don't think there's any that were on the list that were unattainable. And of course, as you point out, many of the things on the wish list are happening or beginning to happen. I think there's still the big challenge that that everybody has on their wish list is the whole issue around data sharing, because it's far easier to talk about sharing data than it is to actually share it. And there are technical challenges to sharing it, there are cultural challenges to sharing it, there are financial challenges to sharing it. So I think that that's still a big issue. It's easy to say, that we embrace sharing data, we have a policy to enable sharing data. It's far more difficult to actually, when you get down to the nitty-gritty of deciding what specific data elements to share, how to share them, who, if anyone, in the collaboration potentially benefits or profits from that data sharing. Those are some really thorny issues that sometimes still impede the actual sharing of the data. It is, but that's the great thing about publicly funded research, is that the NCI is in a position to do it because the research is all funded by taxpayer dollars, and in a sense they have an obligation to the U.S. public who are paying for the research to make the data as broadly available as possible. We're going to have a little discussion that I'll participate in later today about, I think, some of the challenges of implementing precision medicine in clinical practice, and I think the challenges are formidable. I'm a big proponent of precision medicine, personalized cancer care, and so that was my theme when I was president of ASCO, was personalizing cancer care. But what I'm really a proponent of is studying it and learning about it, and more so than just doing it. Because I think that there still are a huge number of unknowns. The biggest problem in my mind, in a sense, taking one step beyond just the issue of the complexity of cancer, but it's reflected in the fact that the variant annotation is still very incomplete. So, when you get these genomic profiling reports, what you get is reports on hundreds of genes and thousands of variants. And the reports, are oftentimes accompanied by some little description of, what is the gene and what is its biological significance. But rarely do those reports say very much about the specific variant that's being detected in that gene. And you saw an example of that in the Watson presentation this morning, where there were some screenshots shown about the reports that are produced by Watson Genomics. And it's the same kind of report that almost any genomic profiling laboratory produces now. They describe the gene, the variant, and then there's a little paragraph that talks about the gene, but rarely talks about the variant. And the problem with that is that in trying to make a treatment decision, what you're targeting presumably is the specific variant that is detected as being abnormal in that person's tumor. And then you have to go through the whole thought process of, well, is this germline or is it somatic? And sometimes you can't even tell because of the way the test was done. And obviously if it's germline, it's not likely to be a drug target and you want to dismiss it. Then you have to go through, okay, if it's somatic, is it pathogenic? Is it benign? Is it likely pathogenic? Is it totally a VUS? And most of the variants that are getting reported, of course, turn out to be variants of unknown significance. So by definition, their biological significance is unknown. That's why they're called VUSs. And therefore it's difficult to understand whether they're making any meaningful contribution to the pathogenesis of the cancer or not, and therefore whether targeting them is of any utility or not. So even if you can, by some means, determine that you should target a VUS, then you've got the issue as well, but then what is the evidence that the drug you're proposing to use actually has any anti-tumor activity in a tumor that has that particular variant? And again, the evidence is typically non-existent. So, from the perspective of the treating clinician, the doctor who has limited knowledge and experience and training in cancer genomics gets this report. The report has, some little pieces of information, most of which actually are fairly uninformative because they describe the gene, but they don't really talk much about the variant. Then the doctor has to try to decide, is this something I can act on or not, and if so, how? What the community needs is much better, much more reliable, and frankly, much more transparent variant annotation, because the variant annotation is not done in an organized, transparent, and sort of universal fashion. There are all sorts of different groups that have sort of undertaken to do this. Some are academic groups, some are commercial groups. All of them are promoting their knowledge bases as being better than somebody else's knowledge base. All of them fundamentally, base their variant annotation on literature review, but they all read the literature differently. They all apply different levels of evidence to weighting the literature. And so the variant annotation is both incomplete and inconsistent across knowledge bases. And then when you get from that to, how is the doctor supposed to apply that? You have a lot of challenges. And so in my view, it's too soon to be doing a lot of this sort of comprehensive profiling and using that immediately in clinical decision-making outside of any sort of learning platform, because there's so much to be learned that if one is going to undertake to do this, then I think you have an obligation to report back to the scientific community in publications or whatever the outcomes that you're observing in your patients, so that all of us can begin to learn from the experience of applying these precision medicine strategies to every patient to whom they're applied. Because if we continue to endorse the notion, which is based largely on anecdote, that every patient should be sequenced because every once in a while there's an unexpected finding that leads to a therapy that produces a remarkable result. And we never really report all the times that the sequencing didn't lead to any treatment decision or meaningful outcome for a patient. We're not really advancing the field. So doing this in practice without doing it in a research setting, in a learning context, in a way in which the results can ultimately be reported and contribute to the global knowledge base about precision medicine, I just don't think we're ready for that. I'm not sure how we're going to get there, quite honestly. I mean, personally, I've thought that this could be a responsibility of government agencies. In the U.S., it seems like the perfect project for the NIH or the National Library of Medicine or some other, global publicly funded organization to take on, to essentially do this annotation, keep the curation alive, do it in a transparent and responsible way, and make the results widely available, and essentially create a public resource for the biomedical community, instead of having this, that, and the other university do it, or this, that, and the other commercial knowledge-based provider do it, and everybody doing it differently. I certainly accept the notion that if patients should be able to access these results. I mean, it's from their bodies, their cancers, it's their results. But that said, the results, as we've been saying, are so complicated to understand. You can't just sort of hand over, a database to a patient and say, oh, here's your cancer genome, have a nice day, because there's almost no way they can act on that information. And so if we're going to do that, we have some responsibility to do it, to a patient in a way in which we are, interpreting it, guiding it, conveying information. I mean, right today, we do all kinds of complicated tests on patients. And, patients have a right to receive all of their medical records. In the U.S., there's a law now that says that, laboratories have to provide laboratory results directly to the patients. That's required by law. But there are plenty of complicated laboratory tests that I could give to a patient that they would have no hope of understanding. I could give them, a printout that shows their, circulating immunoglobulin profile. What are they going to do with that information? And it's just that much more complicated to give them their tumor genomic profile or their circulating tumor DNA profile or whatever. So, as physicians, we have to be guides for our patients. We have to give them the information with some interpretation that they can find meaningful and useful. And if it's not useful, we need to tell them that too. Maybe not create anxiety where there doesn't need to be, not create false hope, but also to place the information in appropriate context so that it can be as useful as possible. So as I was saying, I think the challenges stem from the fact that our information is still very incomplete. That we don't have good annotation, we don't have good clinical decision support for doctors or patients. There's tons of information that comes to every medical provider every day now, and it's difficult for them to interpret it and bring it all together in the form of a treatment plan. And just some of the things we've been talking about. Just imagine the day when, in addition to getting your patient's tumor genomic profile, which now you can get routinely, to what's going to happen then when you get their proteome profile and their epigenome profile. Oh, by the way, somebody's going to offer you a test that's going to give you a readout on their microbiome in that patient. And then you're sitting there and you've got stacks of reports as the doctor that somehow you have to organize, assimilate, interpret, and convert into a treatment plan for a patient. keeping in mind, of course, what the goals of care are, what the patient's preferences are, and so on. It's going to make medicine far more complicated than it's ever been, and that's all the more reason why doctors will need sort of point of care clinical decision support to help guide them, in how to analyze and interpret all this data. But then, that raises the question immediately as to how reliable are the decision support tools, how well validated are the algorithms that those tools rely on. And, if you're using that type of decision support tool to help reach a decision, how confident are you that the decision support tool itself is providing you with high quality and reliable information? So, we are in we're in an information sort of maelstrom these days, and we have to figure out how to bring some order out of the chaos.